Yes, thank
Okay.
you.
So let's understand this point here in this particular case. This is perhaps an oops surgery which I have done, but there is some learning we can manage from this particular case. Now look at this case here. This was a case which had keratoconus. Penetrating keratoplasty was done. Look at the astigmatism. Is about 13 diopters of astigmatism. The pinhole pupilloplasty was done by us. And a mistake I have done is, look at my Purkinje image. It is not centered. The second mistake which I had done was, somewhere mistake was done in the IOL power calculation. And because of that, this patient had a mismatch, bad mismatch, and the vision was about counting figure. So now what we had to do is, I had to go in, first of all, undo the pinhole pupilloplasty. The second thing which we had to do was, we had to also remove this IOL and exchange it. Now you can see the mistakes. There are two here basically, as I had done. One is a decentered pinhole pupil, which is very stupid of me. The second was the IOL power calculation. Now remember, this is a penetrating keratoplasty eye already. So we have to be very, very careful that the endothelium does not get damaged. Once we have cut off those sutures, now we are trying to see, can I take this IOL out? We are worried whether a PC rupture can occur or not. So we prepared flaps just in case a runt occurs. But now we made a scleral tunnel incision, and you can see carefully remove this IOL. Now we are going to put the correct power IOL back inside. The capsule was intact, so we are comparatively safer here. Now you can see that lens going into the sulcus. It's a 3-piece IOL, so we are very safe. Wherever it goes, it does not matter as long as it's a 3-piece IOL. Now, once this is done, now we go ahead and do the single pass 4th row pupilloplasty. You can do any technique for pinhole, but we find this the easiest. And I have to also thank Priya Narang for this work, the pioneering work she's done on the 4th row pupilloplasty. Once you have done this, again, I'm making the pupil smaller. If the pupil becomes too small, watch what I'm doing. I'm using the vitrectomy probe to see that the pupil becomes exactly bang centered with the Purkinje image. That is a key point. But again, made a mistake here, and that is the pupil is too large. So now once we have created this other problem, post-operatively, day 1, patient improved to 660. But on the anterior segment OCT, we saw the patient having a 3.5 millimeter pupil. Now 13 diopters astigmatism is there. So now what do we do to solve this problem? Now at that time, we started discussing with Jack Holliday, and with the help of Jack Holliday, we devised this device, which is the pinhole device of Holliday with epsilon. And you can see there are different hole sizes there. All you do is put it in front of the patient preoperatively and see which pupil he likes. Some patients might like 2 millimeters. Some might like 1 millimeter. Please remember, previously I used to make everyone 1.5 to 2. The patients are all happy, but can I fine tune it better? Now, once you have done preoperatively in this particular patient, we found the patient was very happy with 1 millimeter. So we said, let's go back inside and do it. Now, the question is, can I make it 1 millimeter and accurately do it? So what you need to do is take out the reticule, the eyepiece, and change it to a reticule eyepiece. This is the reticule eyepiece which is available. And if you see the markings there, it shows how much is 1 millimeter. So all you do is, in one eye, you will see the reticule there. So now what you do is, take the patient back to the OR. Now imagine this is the third time I've taken the patient back. Now you can see I'm doing the single pass 4th row pupilloplasty. And on the 4th row pupilloplasty, remember, you need a paracentesis on one side only, where you're bringing it out. The other side does not need a paracentesis, so it's very easy. Bring this loop out. Once the loop comes out, all you have to do is, this is the single pass. Remember the number 4. Pass it 4 times, and that is game, set, and match. You don't need to do second pass. You don't need to do 3 to 2 throws. All you need to do is this, and you can do this in any technique. Even as Kevin showed his purse string suture, if you do the 4th row with the purse string, it will not open up again. So you need not go in again and again to do the knot. Now, once you have done this, remember my target is to make it 1 millimeter, and I'm using the reticule also of the eyepiece to help it. Now, I made it too small. Once it becomes too small, all you need to do is have fluid in the eye through a trocar ACM or an ACM and just use the vitrectomy probe to see that your bang approximately 1 millimeter. What am I trying to tell everyone here is we can now fine tune this game. Patients are happy after pinhole. Can I improve it by 1 line or 2 lines? And answer is yes. Now look at the Purkinje image. It is bang centered. Not only is bang centered, I made it 1 millimeter from a 3.5 to 1 millimeter. The question comes, how did the patient behave? So let's see this patient now. Patient improved to 612. Remember, the patient now has got previously counting finger 1 meter. Look at the astigmatism. It was 13 diopters. We did an IOL exchange, made a mistake of the pinhole being 3.5 millimeter. Vision had improved to 660. Finally, we knocked it down with the Jack Holiday pinhole device made by Epsilon. And then we used the eyepiece using the reticule marker to see that we can fine tune it so that on table, we can get that pupil exactly what we desire. So the moral of what I'm trying to tell everyone is when you see a patient who has got high aberrated corneas and astigmatism, crazy astigmatism, all you do is use the pinhole device, check what is the pupil which is best for the patient. Every patient will not be liking a 2 millimeter pupil. So what you do is decide what patient pupil likes and then go ahead, make the pupil of that particular size. And once you do that, you will see patients even more happy than what they were before. Thank you very much. I'd like to thank Namrata Sharma for doing such a fantastic conference and everyone in the panel.